And we are now recording. And I'm going to hand it over to our wonderful Maryland Democrat Chair.
Thank you, Justin, and thank you so much, everyone. Welcome to MDP's Mental Health Awareness Month event. It affects us all. The COVID pandemic has impacted us all in various ways. And as we slowly emerge back into public, we must address the mental health consequences of 1 million lost family members, social isolation, nursing home lockdowns, virtual schooling, and years of stress caused by the fear of losing a loved one to this deadly virus. Across Maryland, each of our diverse communities faces individual and shared challenges in ensuring that all members of our Maryland family receive the care they need. And you will hear about some of those issues directly from our Diversity Leadership Council chairs. We are also very grateful to be joined by Doctors Goda, Chandra, and Karki, who will help explain these complex issues. We know that mental health care is just as important as physical health care, and the Maryland Democratic Party is committed to ensuring that all health care is affordable and accessible. Maryland Democrats have been working for years at the state and federal level to make mental health care more accessible and affordable. And tonight, you will hear from two leaders on the topic, Congressman David Trone and Delegate Heather Bagnall. Both have shown themselves to be leaders in this area, and we look forward to hearing about our accomplishments as a party, as well as about the work we still have left to do. Thank you so much for joining us for this important conversation. We know it is not always easy to discuss these issues. We further hope that tonight's event will help end the stigma surrounding receiving mental health care, a stigma that exists across Maryland's diverse communities. Now I'd like to introduce Congressman David Trone, who was elected in 2018 to serve Maryland's 6th congressional district, which includes all or part of Montgomery, Frederick, Garrett, Allegheny, and Washington counties. Congressman Trone serves on the House Appropriations and Veterans Affairs Committees and the Joint Economic Committee, where he is fighting to make progress on issues that matter to Marylanders, including the opioid epidemic, criminal justice reform, mental health, and funding for medical research. I have to tell you, the last time I saw Congressman Trone, we were in Garrett County, and it was in late September when we saw each other in person. It was in late September, early October. And at that time, his staff assistant, one of his staffers told the crowd that on that particular day, they had answered 10,000 constituent service requests. That was then. By the end of last year, I know that that number was 15,907. What that says to me is that Congressman Trone and his staff are all about service. It is not about him. It is not about them. It is about you, and it is about all of us. And we are so very grateful that we have a leader like Congressman Trone representing us every single day. So Congressman Trone, the floor is yours.
Fantastic, Yvette. Thank you very much for that warm introduction. And everybody here, thank you for being here tonight. This is a really, really important conversation. As you know, addressing the mental health challenges that our communities have is one of my absolute top priorities. It's addiction, it's mental health, side by side, and they so often overlap. It's an issue that every single one of us has experienced, whether we struggled ourselves or we know someone else that's struggling. It's an issue we don't talk enough about. Many are ashamed of their own struggles or simply turn away from talking openly because of the stigma. And the stigma that's been associated with mental health too long is our biggest barrier. One of the best tactics for success that I've learned in business before, and it works in politics, is clear and open communication. That's the key to making progress. So let me say very, very clearly, I know, and I think we probably all know and love someone who struggles with their mental health. And they, along with countless Marylanders I've met who are in similar situations, They inspire us to continue this fight we're on tonight. We could be having these conversations at a more important time. The pandemic has brought to light so many of the mental health challenges that our folks across the state and across the country face. Over 40% of adults reported feeling depression or anxiety during the pandemic. I know I certainly felt anxiety. These are even more concerning for Hispanic and Black Americans, who reported higher instances of stress and worry during COVID. And our children, even worse. Over 70% of children's parents reported during the pandemic it had taken a toll. The isolation, the technology reliance on their children's mental health. And about a third of high school students reported feeling more depressed and anxious in the last 2 years. This crisis has become even more dire as you consider the fact that 140,000 children lost a parent or a grandparent caregiver to COVID. We must do more. And it's not as if COVID-19 created the mental health crisis. This has been a serious problem we have not addressed for decades. Now it's on the top of everyone's mind, and we need to act. So I've made this our priority in Congress with addiction. We formed the bipartisan, I stress bipartisan, addiction and mental health task force, coalition of 140 representatives, both parties, focused on tackling these issues. We've introduced over 100 pieces of legislation aimed at improving mental health resources, combating the stigma, addressing the ways mental health problems manifest themselves: substance use, suicide, domestic violence. Last year, one bill we introduced was to provide comprehensive behavioral health services to our schools. They've been very hard hit, and we're working to get that to the president's desk. Right at home here in Montgomery County, some of you may recall the tragic suicide of Montgomery County police officer TJ Bomba in 2019. His story is all too common. Brave and dedicated first responders who fell victim to stress and trauma in their work. Coming out of TJ Bomba's suicide, we convened a council led by the head of mental health at NIH, Dr. Joshua Gordon, policemen, first responders, firefighters. That led to 2 bills. Last year, we introduced the COPS Counseling Act, a bill designed mental health assistance to police officers. I'm proud to say President Biden signed that law a few months ago. Came right out of what happened here in Montgomery County. We have a second bill to provide benefits to the family who are left behind. It currently does not happen. That bill just passed out of the Judiciary Committee, and we believe we're going to get that bill over the finish line also. But this progress is just the beginning. For all of us must continue to work until no more families, children, or anyone has to suffer with mental illness. We need to continue to expand treatment, end the stigma, and get people the help that they need. When I finish by just taking a moment to speak directly to those who are listening that are struggling. You're not alone. You have nothing to be ashamed of. And there is help out there for you. Your mental health is just as important as your physical health. We all want to be physically fit. We need to be mentally fit. And it's okay not to be okay. If you're hurting, reach out to someone you trust. Call a friend, a loved one, a neighbor. You do not have to fight this battle alone. We're here together. I know that all of us on tonight's calls are working day in, day out, change America, to get the help that we need. So thank you everyone for having me here tonight. And thank you for being part of this battle across America that we know we can make progress, and we will make progress. And President Biden is very clear in his unity agenda. His number one and number two promotion programs in 2023 are addiction and mental health, side by side. And his budget reflects that. So thank you, and have a great conference.
Thank you, Congressman Trone, for your tireless advocacy for mental health, and thank you of leadership to have the Democratic Party address this very important issue for all our communities. Good evening. My name is Devang Shah, and I serve as the chair of the API Democratic Leadership Council. Now, we are here today because we care deeply about the well-being of our communities, especially our children. One of the primary factors impacting our well-being is our mental health. Yet this important issue is consistently brushed under the rug, neglected as a legitimate health issue, allowing individuals' mental health to continue to worsen, making many feel invalidated in speaking up about their mental health struggles. In our API community, let me give you a very common scenario. Your child falls and breaks their arm and you rush them to the emergency room. Or your child wakes up with a fever and sore throat, so you take them to the doctor's office. Yet, when your child begins struggling in school and demonstrates signs of mental health issues, their school counselor reaches out suggesting therapy. Therapy? You write it off, not understanding how therapy would fix the poor grades you saw on the last report card. You tell the counselor there's nothing wrong with my child and they don't need fixing. You know, it's this lack of acknowledgement and reluctance to address the struggles of your child only further harms them in the long run. The stigma surrounding mental health services is just that, a stigma. By playing into this very dangerous stereotypical API outlook that mental health struggles equate to a wrong in a way that a common cold does not, we are in fact enhancing the stigma as opposed to working to get rid of it in our API community. So our children's children can flourish without the fear of appearing weak when they so bravely seek out help. And in the API community, we are in dire need of this cultural shift, with the API community having the lowest help-seeking rate of any racial ethnic group in the United States. Of APIs with a mental illness, just 23.3% receive treatment annually. Now, we've come so far as a community in this country, breaking societal norms of what is considered taboo to talk about, realizing that in many cases, taboo simply meant ignoring the reality of an issue in order to avoid addressing said issue. Today and throughout this month, we want to bring attention and address the extremely high prevalence of individuals struggling with mental health challenges. 15% of APIs in the US have reported having a mental illness in the past year. Without bringing this awareness to the issue, we cannot move forward to create change in the way we legislate mental health treatment programs, the way we see mental health as having mental and physical impacts, and the way we push for more culturally competent care that is considered to the challenges of our community specifically faces. We must push government agencies for disaggregation of data because our API community is so very diverse. And we need to support the efforts of elected Democrats that push for affordable health care for all, including mental health care. So we need that mental health care to be culturally competent. So let's work with the Democratic Party and its elected leaders to address this serious issue within our community so we can all get the help that we need. Thank you. At this time, I'd like to welcome Stephen Papala from the Person with Disabilities DLC.
Good evening. Thank you for having me. And thank you for having me this evening. So among the things that is seldom talked about, especially within the disability community, is the mental aspect of what people go through and what are some of the ways that we can help advocate for better support, better access to care. And one of the things that have become, as Devang had mentioned, that there is a stigma, not only the stigma of mental health, but also the stigma of trying to find help. Because a lot of people, they find that if you talk about what's bothering you, or if you talk about your problems and what ails you, that it makes you weak. From a personal perspective, I can say I have actually struggled with depression, anxiety for over 30 years, since I was a teenager. And it's something that, my family growing up, we didn't talk about things that bothered us, or it was just, if I did something that was wrong or did something that was unusual, it's that, oh, it's just boys will be boys. Well, that's not always the case, obviously. And I wasn't really given the opportunity to seek help when I was a kid. It was especially as a teenager. It wasn't until later on in life I realized that what my struggles were based on, and why, realized why it took so long for me to seek help. The biggest problem has been that when people, I always like to say that bad things that happen, it can affect you mentally. Like one bad thing. And I always say it takes at least 3 good things for you to get past that one bad thing. And the reason why I say that is because, it's sort of like anything you hear in media. If something bad happens, you always think of the worst what's the worst that could happen? And then even if you hear about a good thing that happened, you're thinking, that's cool. But, you think about the bad thing, and it takes a while to get to do away with that fear. With mental health, it's not like that. Mental health has been such a difficult thing to grasp, and it also explain to people, because when you grow up with the family or grow up with people that don't necessarily believe that there's such a wide variety of issues that people suffer mentally, when you're older, it becomes even more difficult for you to reach out and accept help. So within the disability community, it is especially difficult when we have someone who suffers from mental health issues that sometimes they're not always getting the right help, or they're not being, they don't have the ability to seek help. One of the things that, I have had a friend who suffered from, bipolar. And when she would go on an extreme level of mania, she would think, okay, I'll take medication for a little bit. And the problem was she would take medication for a little bit and she would get better, but she didn't have the support to make sure that she stayed on it. And that's something that we really, as a society, and also as the Democratic Party, need to make sure people are aware that they can get help, that help is available for them. And even if it's just a matter of talking, and just listening to what they have to say, it does help. And so that's something that I truly hope that we as, not only as a society, but we as human beings are able to do going forward.
Thank you, Steve. Thank you, Stephen. I'm Kent Roberson, the chair of the Maryland African American Diversity Leadership Council, and I want to thank our chair, Yvette Lewis, for this opportunity to join with the other DLCs on this great event. Just the fact that we are bringing a highlight to mental health issues is important. And I think it's one that we can't shy away from. And we've seen, especially among elected officials, the toll that it takes on us and the roles that we play. So I just want to say thank you once again for the opportunity. Thank you for allowing us to collaborate on this. And I look forward to the continued conversation after this event. And with that, I'll turn it over to our LGBTQ+ chair, Ms. Mia Mason.
Good evening, everybody. I am Mia Mason. I am the Democratic primary winner of Maryland District 1 back in 2020. And I have to say that no matter if you win or lose out there, the hardest thing is dealing with mental stress and mental health and finding mental health. As part of the LGBT community, we're often turned away. But it is something that we honestly need more help and assistance with, not only in the state of Maryland, but also throughout the nation, because right now our country is being attacked by the GOP. They want to strip away our healthcare. They're doing this through Roe versus Wade. They're eventually going to try to continue to attack our LGBT. They come out with bills that say, don't say gay. And then they're eventually going to come after all of us in our other TLCs. And I'm so thankful that I am here with you, Yvette Lewis and Congressman Trone, and all of our wonderful panelists who are going to be answering our questions, because one of the things that we have to discuss is that fear that causes the anxiety and media disorder. And I have to say that with this, we're going to be able to make a change, because as a military veteran, I know that I've dealt with homelessness. I've dealt with so much in my life going to war from 9/11 to present, that I switched my life to fight for my community, my LGBT community. I'm looking forward to all of your questions being answered to us. And I'm looking forward to our next speaker, who is Edward Holland of our Veterans DLC Chair. Thank you.
Yeah, thanks, Mia, and evening, everyone. I'm glad to be joined with so many wonderful DLC chairs, and I'm honored that State Party Chair Yvette Lewis chose me back in 2014 to be her Veterans DLC Chair, so I'm still here. More importantly, I'm pleased that we are discussing the issue so important to veterans' mental health. What percentage of veterans have mental health issues? About 41%, or about 1.7 million veterans, according to the Veterans Administration. The VA Mental Health connects veterans to mental health services that the VA provides for veterans and families. All mental health care provided by VA Veterans Health Administration supports recovery. The program aims to enable people with mental health problems to live meaningful lives in their communities and achieve their full potential. The three most common mental health concerns for veterans are post-traumatic stress disorder, better known as PTSD. I'm sure you've seen enough movies on that. Depression and traumatic brain injury, better known as TBI. You can learn more about these mental health issues, concerns by just going to the internet. Emotional symptoms of TBI, or better known as traumatic brain injury, are irritability and anger, depression, insomnia, anxiety, and I've already mentioned PTSD. Why is mental health important to veterans? Individuals trained in mental health first aid can help to break down the stigma associated with mental illness, like anxiety, depression, PTSD, as I've already touched on, schizophrenia, bipolar disorder, and substance use disorder. So we always say that you should reach out to a healthcare provider, and that do this in silence. I can explain many times, being a combat Marine, how many times I've seen fellow Marines self-medicate with alcohol and including drugs, and because they refuse to seek help, because the Marine Corps, of course, is one of the services that frowns on seeking mental health. So being a veteran and a combat veteran of that, I definitely am pleased that we're discussing this issue tonight. With that, I will now turn it over to May Beal, the Senior DLC Chair. May, you're up. You're on mute, May. You're on mute.
Okay. Good evening, everyone. I am May A. Beal, Chair of the Senior Diversity Leadership Council, for those who don't know me. Welcome to our DLC Mental Health Awareness Month virtual panel discussion. I'm pleased to be here with my fellow DLCs, the host for this event. We have with us this evening a dynamic group of panelists to inform and educate the public and give you a better understanding of why mental health is a vital piece of who we are and how we function and behave, whether psychologically, emotionally, or socially. Our circumstances affect each of us differently and play a significant role in adapting and managing change. The goal this evening is to raise awareness of the mental health challenges confronting our residents in Maryland in recognition of Mental Health Awareness Month. In addition, to emphasize the importance of working with our DLCs as we move onward and upward to be victorious in 2022. Thank you.
Hello, everyone. My name is Dr. Pallavi Gowda, and it's an honor to be here among such esteemed a group of individuals and who really matter and make a difference and find mental health just as important as I do. So thank you all for taking the time. My name is Dr. Pallavi Gowda, and I'm a medical doctor in internal medicine. I'm a U.S. Army veteran and a mental health advocate. And I would like to say, most importantly, I have a history of depression where I saw a psychiatrist. There was a period of time where I took medications, and I am in a much better situation and place. And so I like to state that because important for viewers to understand that we can be in any stage of our life, any professional field, and be affected by depression. And we have to state it just as much as we have hypertension or we have diabetes. We can say I had depression and I am have recovered. Just a few days ago, I attended the funeral of a 26-year-old. And the whole time I sat there going, this is not right. This is not right. Our system has failed us. It's easy to blame an individual in such a situation because she took her own life. She shot herself at home. And so all I could think was the system failed her. So this is why we are here today. This is why it matters. We have a great panel of speakers who are going to answer very important questions. I will be checking the chat at times in order to see what questions are posed there. Our three speakers, and I'll just list them briefly. I will then talk about mental health disorders, and then we'll go into more of their bio and questions. So Dr. Rohit Chandra is a child and adolescent psychiatrist. Dr. Shyam Karki is a clinical pharmacologist specializing in psychiatry. And Delegate Heather Bagnall is from District 33 in Arundel County. So like I said, I'll review their bios in just a moment, but why are we here? What is the impact of mental health? It is such a huge impact in terms of millions of Americans are affected by mental health issues. Thankfully, the conversation has shifted from being a taboo to more of a public and a healthy approach. Mental health is defined as our psychological and emotional well-being. According to mentalhealth.gov, this can be affected by biological factors such as genetics, brain chemistry, life experiences, trauma, abuse. Family history of mental problems is also a factor. The National Alliance of Mental Health reports that 1 in 5 adults in America experience a mental health illness in their lifetime. 1 in 5, that's pretty significant. Right now, nearly 10 million Americans are affected with a serious mental disorder. The most common mental health disorders are anxiety and depression and bipolar disorder. They fall under a group of mental health disorders called mood disorders. According to mentalhealth.gov, anxiety and depression is highly treatable, and around 37% of those affected actually receive care. It is commonly diagnosed with both anxiety and depression. Symptoms can include excessive worrying, feeling agitated, restlessness, fatigue, tense muscles, difficulty sleeping, and panic attacks. Now, major depressive disorder is a leading cause of disability in Americans from age 15 to 44. This disorder is more prevalent in women than men. Some of the symptoms include depressed mood, diminished interest in pleasure, change in weight, appetite and sleep patterns, fatigue, and a feeling of worthlessness. Lastly, I'll just mention bipolar because it is the third most common. So bipolar disorder affects men and women equally. The median age of diagnosis for bipolar disorder is 25 years old, but it can develop later in life as well. Those who suffer from bipolar disorder experience manic episodes where their moods and behaviors are drastically different than normal. These changes can include unusual hyperactivity, sleep patterns, just activity in general, Diagnosis of bipolar disorder is done by a medical provider with a psychiatric evaluation and charting the moods over time. So I remember, what gets a lot of people through higher professional studies like medical school is mnemonics. So the mnemonics we were told in medical school that's just stuck in my mind, I like to share, is SIG-E CAPS. And I'll tell you what each of these stand for, but these are the individual symptoms to look out for depression. They usually last 2 weeks, and you have to have more than 5 of these symptoms. So the SIG-E CAPS: sleep changes, loss, so interest, I is interest, so loss of interest in activities that you normally enjoyed, guilt or a feeling of worthlessness, that's associated with the depression. Energy is the E part, so lack of energy usually. Concentration, cognition is often affected, so C can be cognition or concentration. Appetite is the A, and the P is psychomotor agitation. It can be anxiety or it can be lethargy, presents differently in people. Lastly, a preoccupation with death, so suicidal ideation. So SIG-E CAPS, that's a good mnemonic to remember. The most common groups that are affected are individuals who are going through extreme life stressors, as stated before. Drug addiction is another. The opioid epidemic we know has, in 2019, it was reported over 70,000 died from opioid addiction. Youth. The other I would like to, and elderly. The other I would like to include are usually women who have fluctuation in hormone levels. So hormone levels like girls who are starting their menstruation cycle, pregnancy, and menopause. Those are 3 critical times there where the hormones are heavily affected and are fluctuations, whether it's an increase or whether it's a decrease. And mood is often influenced or affected. So be kind to women who are going through these stages. Evidence-based practices, I'll just end on that. So evidence-based practices are interventions that have a strong scientific proof and they can produce positive outcomes for certain disorders. So they involve psychotherapy, multidisciplinary, especially when it comes to elderly and geriatric population. So there's a multidisciplinary approach, a collaborative, integrative mental and physical care. So the mental health specialists and the primary care docs and just doctors in general have to work closely. And then we'll have our clinical pharmacologist who will talk about antidepressant medications. But some of the challenges that I've noticed are people are not aware of the resources that are there. So I'm glad we're having this today. And then repeatedly, I have heard today the stigma that is often associated. And I am here to say that is the main reason that I start out by saying I had depression. If we can all say that, then it seems like, just a common thing that we just have to address, another hurdle in life. The change starts with us. So resources, at least when it comes to adults, Dr. Rohit Chandra is going to talk about our pediatric population. Primary care doctor, by profession, I'm a primary care doctor, so I've got to promote primary care, senior primary care doctor, counselors, and there's multiple social programs that are available in the county that you live in. And our delegate is going to talk about health policies that influence health. So I'm going to now introduce Dr. Rohit Chandra. He's a child and adolescent psychiatrist at MGH Chelsea Healthcare Center and is an instructor of psychiatry at Harvard Medical School. He chairs the board of the South Boston-based arts and healing nonprofit Spoke and serves on the boards of the Mental Health Initiative and Volunteering for Seniors. He has an aunt and cousin in Montgomery County, and he's proud to work with RhodaCare Maryland Free Clinic that I'm also a board member of. So Dr. Chandra, we'll get started. What are the common symptoms that you see in children, and then what are the different influences in terms of whether it be social media or whether it be electronic use, and just access in general? What are the common things that you see in terms of children?
Sure. Thanks so much for having me. Hope everyone can hear me. I think the disorders that are seen in children are, the ones that have been mentioned: depression, anxiety in various flavors, bipolar disorder, which, as you correctly said, Akata, is under the umbrella of mood disorders. Depression, bipolar are mood disorders. I work in a fairly poor community. People have been fairly traumatized. So I see a lot of PTSD, post-traumatic stress disorder. And in kids, we see a lot of ADHD, attention deficit hyperactivity disorder, and autism spectrum disorders, which are, it seems like, truly on the rise. So those are some disorders I see in kids. Psychotic disorders can also begin to rear their heads really in adolescence. See adults. I actually see about 2/3 adults, 1/3 kids and adolescents. So I can also talk about adult psychiatry. Thanks.
Thank you. Now, you've done a lot of work and written a lot of papers on suicide prevention. Can you share some insights on such an important topic?
Sure. You and I had talked about the Naomi Judd suicide. She died through shooting herself in the head. I mean, these are high profile ones. Someone else today had mentioned, a 26-year-old Montgomery County person who died by suicide. So, I mean, these are preventable deaths by and large. There are different reasons for each person to feel suicidal. Sometimes it's fairly biological. Someone has major depressive disorder, someone has a bipolar disorder, and insufficient treatment for either one of these can lead to suicidality. I have patients who are under a lot of economic pressure. Their job, they're not making enough at work. They may be losing their housing, so financial stress can be a component to suicidality. There are a number of pathways to it. But ultimately, I think, like Congressman Trone said, we need to expand services to get people the treatment they need. And if there is a backlog, if there's a strong need for people who are depressed and suicidal, and they don't have access to services, you really can get completed suicides, and that is, that's really concerning. But I mean, the tendency is, for someone to become depressed. Mood disorders are implicated in a fair percentage of suicides. Also, substance use is a high predictor of suicidality and completed suicides. So I think really, suicide prevention involves treating mood disorders, treating substance use disorders, and just, really monitoring someone who is suicidal and devoting resources to that person, making sure that they get what they need, that their symptoms abate. I think as Devang Shah had said brilliantly, I actually used the same breaking arm analogy, that mental illnesses, are very treatable if someone does seek help. If someone breaks their arm, Asian families and families of people of color will often take their child, will take their loved one to the emergency room, but we do not do the same thing if someone is struggling with mental illness or mental symptoms, and that is really a failure. We need to overcome that stigma in order to get people the help they need. So the points made have been one.
Sure. Now, as a parent, and I would like to know, what is the impact of social media in general, electronic use? Are parents just paranoid, or what is the impact emotionally on children?
Right. So this is a really important topic. There's a psychologist named Dr. Jean Twenge. She's at San Diego State, and she has noted that since the introduction of smartphones, since really the widespread adoption of smartphones, the rates of depression and anxiety among teenagers have spiked. That's correlation, not causation, but there are some reasons to think that there may be causation here. One is that smartphones emit blue light, and blue light is known to decrease sleep quality as well as increase sleep latency, meaning it takes a longer time to fall asleep. Blue light actually suppresses melatonin, which is kind of the sleep hormone that the brain produces increasing quantities of as the light outside goes down. So if we're using smartphones in the evening, at night, it really often is difficult to fall asleep. If you're not sleeping well, now you get a whole host of problems. It can be more irritable, you can be more anxious, generally more stressed. That's one possibility. Another is that social media like Facebook and TikTok and Twitter, I mean, they can fragment attention. We are often, rather than being focused and relating to people face to face and having conversations, we are instead scrolling through our feed. We are instead, just our attention is fragmented, and we're not getting the same quality of social interaction as you would if we just sat down and had a conversation with someone, had dinner with someone, sat and talked. So our worlds are kind of in our phones, or in our iPads, or in our devices. We're sort of in these devices in a way, and stuck, and often cannot get out and cannot relate to others properly. And that really is troublesome for youth. It's troublesome for us as adults as well. So those may be some factors in terms of why social media and smartphones are problematic.
Sure. Thank you so much, Dr. Chandra. So next we'll have Dr. Shyam Karki. He's a clinical pharmacist specializing in psychiatry. He worked as the director of pharmacy and hospitals in Maryland, New York, Washington, D.C., and was a professor in pharmacy in the School of Pharmacy before he retired. He's very much involved in our community organizations and healthcare issues. Medications. So Dr. Karki, welcome. And my question to you is, why are patients reluctant to take medications? Do you find that they are, and why are they?
Good evening, everyone. That's a very interesting question. Actually, when I practice is when the patient doesn't respond to usual medication, then the psychiatrist refers the patient to me. And the first question I ask the patient is, are you taking medication? The reason is, no matter how good a diagnostician you are, how well you prescribe, if the patient doesn't take it, it doesn't mean anything at all. So we have then before I ask the patient, I have a lot of other uses I use. We do the pill count, we do the refill tracking, and then there are special vials that tell you how often they have been opened. And then for some patients, you can go and check blood levels also. So we use these to make sure whether the patient is taking or not. Otherwise, patient will most of the time will say, yes, I'm taking it. But once I tell him that I have a lot of other techniques by how I know they take it or not, then they become much more frank with me saying, no, I missed some of them. The reason for that one is multifactorial. First thing is there's a stigma attached to the mental disease itself, and there's a stigma attached to taking medication also. Luckily, the stigma attached to the mental illness is slowly going down, but still then people think, you must be weak. How come you cannot control? How come you cannot relax? You got to be a little bit strong in mind. You got to work it out. People have this kind of expectation that someone who takes medication is very weak. That's why he needs to take medication. They need to do it by themselves. Then I tell a patient that, look, when a patient gets pneumonia, you don't tell the patient that go out for fresh air, take good nutrition, rest. We don't tell them that one. We tell them, take antibiotics. Doctor comes and tells them, take antibiotics. It cures them. Then only after the pneumonia is cured, then you have time for all those things. The same way, mental health also is a very complicated factor. It's a question of hormones, level of hormones, the people's capacity to cope with stress. It's a lot of factors, and it's not a question of strong mind and weak mind. So I tell them saying, there is nothing wrong with taking medication. Actually, people who are very mature, people who are very self-confident are the ones who say, look, I'm in a position, I need to take medication. If I take it, I become much better. So it's the people who are bold, who are strong, they are the ones who take medication, who are not, got down by other people who try to ridicule them. So I have a monthly talk with the patient saying, it's very important to take medication. And there's nothing wrong taking medication. Actually, if you don't take medication, there is something wrong. Then you are afraid of something. So I give a lot of inducement to take medication. But still then, there are a lot of barriers. There are a lot of other barriers to take medication. We call them what we call the adherence factor, I mean how often the patient takes medication. it has been shown that 50% of the patients don't take medication as prescribed. And there are multiple reasons. One of them is they don't know what kind of medication they are taking, especially when it comes to psychiatric medication. People don't want to take medication in front of the peer group, in front of other people in the class. So I make sure that patient gets medication only once or twice a day. I tell them nobody should take medication 3-4 times a day. So I convert those medication to some other medication form that can be taken once or twice. That way they can take the medication at the time they're choosing. They don't have to take it in front of others. So there is no reason for them to get embarrassed saying, I have to take my medication. The second one, the most important other one is the psychiatric patients are quite different nature. Like to give you an example, the schizophrenic patient is already thinks that there is someone to get him, there is someone to poison him, there is someone to harm him. So he thinks that when someone gives a medication, it's something they are giving him poison. And very interestingly, all psychotropic medication we give in the early stage, you get side effects. The therapeutic effect you get only after a couple of weeks. So the patient thinks, I knew he's going to poison me. You see what he did. The same thing. Same thing in depression also. It takes you 4 to 6 weeks to start getting effect. But all effects start getting right from the next day. So it's very important to talk to the patients and tell them what are the side effects we expect, when they should, when it becomes very important that they should call the doctor and talk to them. Another thing very important is not all patients have the same attitude to side effects. There are some side effects, like to give an example, patients, if you take them, you gain weight. I want to give that kind of antidepressant to a young lady. Thing to give to the frail elderly who is losing weight. So it's a question of matching lifestyle, matching what is important for the patient, and you're designing the drug therapy with the patient. It's very important to take the patient in confidence, because sometimes we, the professionals, have a paternalistic attitude to the patient saying, I know the medication, I know what works, what doesn't work, so it's for you, without caring what are the interests and what are not interests. So it's a very complicated field, and the adherence factor itself is a very interesting, and so I find it very fascinating. And there are many ways of how to increase this adherence factor. There are many ways of doing it. And there is special research done in what makes them better. And then especially in chronic disease, it's difficult. The reason is in acute medication, you have only 10 days to take. You know it. Once I had to take a medication for 1 year, and me teaching everyone how to be adherent, at the end of the month, I just have 2-3 pills left over. That means I missed some medications. So from that factor, it's very important to teach the patient that what are the consequences of not taking medicine. Because, because they have to know that one, because if you miss a couple of doses, people think, look, it's all right if I miss, so what? But the trouble with schizophrenic patient is, if they miss a couple of days medication, they have lost that insight that they must take medication. So they have reached this stage whereby they will start completely taking medication. So from that perspective, it's very important to tell them that it's their interest, why it's their interest, why they should do it, why they shouldn't do it. So you have to do a lot of teaching. And nowadays, teaching and time is in very short supply. And it's a very tough world to live in. So without this, with this one, I'll conclude. If you have other questions, I'll go in more detail, because knowing working in this field, I've spent years, so I can speak for hours only on this topic, but I will stop here and wait for your questions.
Sure. So one other question I had is, what are and you kind of touched on this, what are the different factors in terms of compliance? How can we ensure more compliance? And is there a difference that you've noticed in terms of children and adults? Do you notice that children, are they amenable to taking medications and versus parents having any influence? What is your experience on that? And then we'll go to the delegate afterwards.
Children usually, it's a question of relationship between children and parents. And parents are in a very good position to tell the children that it's in their interest that they should take medication. And have a good dialogue with the children also, and make sure that, again, for children, you can find medication in different tests. So you have to make sure that, being a pharmacist, I know how to put different medication with different flavor. So it's very important to know that, like someone who likes a honey taste, you don't want to give that with bitter medicines. You just want to put that medication with honey so that the patient likes it. So it's a question of, again, matching patients' interest versus the medication. Sometimes it's a slow job, but once you do it, it stays for a lifetime.
Sure, great. Thank you so much. That was very insightful. Next, we'll go to Delegate Heather Bagnall. In 2018, Delegate Bagnall was elected to the Maryland House of Delegates to represent District 33. She's a member of the Health and Government Operations Committee and Health Occupations and Long-Term Care Subcommittee, as well as Public Health and Minority Health Disparities Subcommittee. Bagnall is a member of Women Legislatures of Maryland Caucus and Maryland Legislative Transit Caucus and Maryland Legislative Latino Caucus. The cycle, what's that? Oh, I thought someone said something. This cycle, she has received endorsements from the Sierra Club, the Maryland State Education Association, Strong Schools Maryland, and the Humane Society of Legislative Fund. So Delegate Bagnall, welcome. And so my question to you, first one, in terms of mental health access initiative, how did it come about? What has been the impact of the legislation? Is it more meaningful or essential given the pandemic? And what are the steps to adolescent access to mental health care?
Well, thank you so much. And thank you for including me in this very esteemed panel tonight. I have had a passion for mental health in the legislature. I think one of the earlier panelists made the point, if you had everyone close their eyes and raise their hand if they'd been impacted in some way by mental illness, every hand would go up if people were being honest. And in 2018, I guess early 2019, I had a group of youth advocates that actually came and asked for a meeting in my office in response to a very high profile suicide in their community. They didn't like the access to services that they had. They felt that that they weren't being heard and that their needs weren't being met. And so when we worked together, we discovered this huge discrepancy in the law between how we address substance use disorder and how we address mental illness for adolescents. Substance use disorder has no floor age for providers, and these are licensed health providers to provide services, but mental illness had a floor age of 16. So we worked on that bill for about 2.5 years and passed what is the Mental Health Access Initiative, which actually lowered that age to 12, but you still have to meet the standard of mature and capable of consent. And as the doctor earlier said, you always want to involve the family, but there are circumstances where it is not necessarily in the best interest of the minor child to make that first phone call. When we worked on this bill, obviously it was controversial. Anytime you're talking about consent, it does worry people. And I said, I think this is the one consent bill that people will understand. It actually will be bipartisan. And as it turned out, we were correct in that assessment. We did not know that the pandemic was coming. And that bill has actually become really important because it only applies to licensed health providers, people that are licensed under health occupations. Essentially, before we passed this law, any adult could talk to an adolescent except somebody licensed and trained to help them. So now that we have had this experience with the pandemic, we're finding that the need is even greater for our adolescent communities. Adolescents are aware that they need help, and this created another access point for them to seek that help, even if it's just talking to, even if it's just talking to somebody at their school who can say, okay, well, let me connect you with a provider, which is what happened previously. If an adolescent said, well, I have, you know, I think I have a problem with alcohol. I think I have a problem with substances. But if they came in and said, I think I have, you know, an issue with depression, that was the end of the conversation. So I know going forward, you know, this was just one access point. We still have to address how they access those resources. But we have passed, you know, we passed the school-based health centers. So that's going to become an access point. Community centers are an access point. Health departments are an access point. And it's just addressing this small gap community, which unfortunately during the pandemic has actually become a larger community. But I also think that the work that we did on that bill also helped highlight the need. And so I think we've actually gotten more support as time has gone on.
Great, thank you so much. That's so informative. My next question to you is, can you talk about the Psychiatric Hospital Admissions Equity Act and the role equity plays regarding your approach to behavioral health policy?
Well, I think an earlier panelist talked about the need for culturally competent care. Equity is a huge issue with any sort of health policy, but particularly when you're talking about behavioral health policy, because behavioral health issues are probably the stigma is the most intersectional that you have in terms of healthcare, because there is stigma in every community and it all looks different. So the bill that we passed, the Psychiatric Hospital Admissions Equity Act, was actually it was a sort of a preventative measure, because previously there was a policy and it had to do with funding, but there was a policy that required a number of phone calls if somebody needed a psychiatric, if they needed to be hospitalized for any length of time, they had to make calls to hospitals that would accept Medicaid prior to going to a specialization hospital, a specialized psychiatric hospital. It wasn't medically necessary. It really had to do with funding. So we passed a bill that said that any decisions, any policy decisions regarding admissions had to be based on medical necessity, not on financial basis, and that they had to go through a review process to make sure that the policies that we were passing were creating equity between our most vulnerable communities, you know, our lowest income communities, and our communities who have more resources to access those more specialized services.
All right, just a second. Sorry about that. But thank you for that information. That's very informative. In terms of the Behavioral Health System Modernization Act, this was a priority bill for your office and it stalled in both chambers. What are you trying to accomplish and what's next?
So the Behavioral Health System Modernization Act was a very ambitious bill. It was an omnibus behavioral health bill. Now, of course, in Maryland, we can only have omnibus bills that are under a single issue. We don't have bills where we can say, oh, we want to, you know, put in this tax cut under this behavioral health bill. That's not how Maryland policy works. But this was an omnibus bill that addressed 5 different aspects of our behavioral health system. Maryland actually has a really good behavioral health system, and we're working to have a really great behavioral health system. A lot of the pieces that were within the bill ended up in other policies. So there was a policy that we passed regarding reducing violence in Baltimore. It was a pilot in Baltimore, and it really sort of touched on that community behavioral health centers piece and on the peer-to-peer services piece. And so we touched on different aspects of it. We also had a piece in there for mobile crisis units, and we had a separate bill that addressed mobile crisis units. So I think the next step is that we want to evaluate what we were able to accomplish and also what has been funded, because there are some issues with the reimbursements of our providers. We're having a real crisis of workforce because our providers who are providing services to our most vulnerable communities are not getting reimbursed in a timely manner. And it's actually putting that entire community in jeopardy because it's forcing providers to make decisions based on whether or not they can even afford to continue to provide those services. So the next step is to evaluate what we were able to do, how it coordinates, and then draft the policy to fill the gaps where we can identify them.
Thank you so much. That really answered my question. Any other last minute thoughts? That's all the questions that I had. Does anyone from the group have any questions, or the panelists have any last minute thoughts?
I have a question which I can to ask regarding medication. So one of the things that was especially problematic for me was finding the right medication for my depression and anxiety. And one of the things that I've noticed, full disclosure, I actually take Lexapro. And I've been on it for a little over 2.5 years, done great for me. But one of the things that I've noticed was that the increment, basically I was told either, do 10, it did well, try 15, and I was told to go back to 10. Well, something I talked to my doctor about was microdosing, because 15 was a bit too much for me, but it really killed off my anxiety. But I was a zombie, like a total blank. What are your thoughts on microdosing? Because with the consent of my doctor, I said I wanted to try 12.5. I know that the pills are very small by then, but to me, that was like a total sweet spot for me. 10 was okay, 15 was too much. And I just wanted to get your take on microdosing, just to make sure that, okay, for each person it's different. So what are your thoughts on that?
That's a great question. Go ahead, Dr. Chandra.
Sure. Yeah, I think ultimately what one is looking for, I think what you're looking for is reduction in symptoms, ideally being symptom-free, and not having side effects. So whatever can lead you to that would be ideal. If 10 is too little and 15 causes side effects, then 12.5 sounds reasonable. Now, your doctor may or may not be willing to do this. That's sort of the trouble, that you may see this very clearly and say, this is what I would like, but obviously working with your doctor can be a challenge. Sometimes doctors do not want to give doses in between the normal increments, so that is a challenge. But it certainly seems like it's worth a try. If 10 is too low to help you, 15 is high, you get side effects, then 12.5 sounds like it would work well.
Your thoughts, Dr. Karki?
I think the question is, I think much more to do with saying they are not available in those form, right? 15 milligram, 10 milligram, if you want 12 milligram, you cannot find it. I think in that case, he has two ways to do. One is you can go and get suspension. Suspension, you can always decide how much you want to take. The other one you can do also is you can take 10 milligram one day, 15 milligram other day. The reason is what happens is, now to speak in kinetic terms, we call the steady state where all the drug goes to a certain level. So if you do alternate that one, actually I did a research when Zoloft first came, it was the same price, but 50 milligram, 100 milligram. And the hospitals were asking me, what can I do? Can I give 100 milligram to a patient every 3 times a week instead of 50 milligram 7 days a week, because he saves almost 60% of the drug cost. So I said, okay. So I did a research, all these patients giving first 50 milligram dose, taking their Hamilton Depression Scale, all those things. Then I converted them to 100 milligram 3 times a week, and did the same thing, didn't change. That showed that the half-life of that drug is so long that whether you give once a day, once every 2 days, doesn't make a difference. So it can be done. Only thing in his case, one thing is if you go to pharmacists, either they can make a suspension for him, so that way it gives him the choice of how much to take, or you can do 10 milligram one day, other day 15 milligram, and come to an average dose of 12.5 milligram. There are always tricks to do. Always there are a bag of tricks you can use to come with the different choices. So you can do that one.
I have a question. This is May.
Oh, go ahead, May.
And my question is, one shoe doesn't fit all. And what I find in some instances that doctors will prescribe something, maybe he's been prescribing it to other patients for a while, and he will say prescribe it to you because he thinks it works. But what I found that our bodies are different. What might work for you might not necessarily work for me. And I think that we as adults or individuals, even our children, because I remember years ago, it's been many years ago, when they had prescribed Ritalin, a long time ago, for my son when he was little, because they say he was hyperactive and stuff. And I tried that. My son was so lethargic and so out of it, I just stopped it. I said, if this is how he's going to be, he won't be taking this. And I'm telling you, that was the best move I made, because why would I want my son sitting around, not able to move, sleeping, not eating and all? So I think that we as patients, sometimes doctors don't want to respect who we are, because I know I can't take medication at all. And when I had a major operation, my doctor said, well, you got to take this, I said, well, if I'm going to die from the medication, I may as well die from not taking it. So my point for saying that is that very, very respectful of people when they're telling you that, hey, doctor, and seeing the sad thing about it, we trust doctors. We don't have any other alternative. You are the specialist. So we rely on you to help us. But when we come to you to say, wait, doctor, it may have worked for the other 500, but I'm the 501. It is not necessarily working for me. What is the alternative? And sometimes the doctors push back. They want you to continue to take it. So I think there's something that we have to consider and have to kind of work through that, and most patients are just take it because the doctor prescribed it. They don't know any other recourse.
Yeah, I think you're very right. I think we doctors really have to listen closely to feedback and just push whatever it is that we want or think should work for someone because we went to medical school. That is, you're right. Each person is different, and brains especially are different. Like our hearts are probably not so different structurally. So if you give a beta blocker to someone, and to a lot of people, it should slow down everyone's heart. But if you give an antidepressant, certain type of antidepressant, to a variety of people, it may work really well for some people, may cause terrible side effects. Others may trigger worsening symptoms in some people. So I think it's very true that psych meds are really very individual, and the last person was question, but ultimately, what we should try to do as doctors is figure out how to relieve symptoms, to make sure our diagnosis is right, relieve symptoms, not cause side effects, because you're looking for help. You're not looking to fix one problem but cause another problem. You're not looking for your son to be zombified or otherwise totally sedated. You want help. And if one med is not doing that, then that doctor should switch the med and make sure the dose is appropriate, not too high, not too low. It's true. Doctors often don't listen. There's a book by Leanna Wen, who I think at last check was the Baltimore Commissioner of Health, and it was called "When Doctors Don't Listen." And it's
and I just had to add one other point. I have a habit, like if I do an accountant T, and if those side effects outweigh I don't take it. I don't care what it is. Because
Very-
if I'm gonna be, look, if I'm gonna be not be able to see, not gonna be able to walk because I'm taking, they're telling me that on the package. You know how they have the, now they have to really identify what the side effects are. And I'm telling you, when I read it, and my doctor and I, we battle all the time because I said, no, I'm not taking this. It's got too many side effects. I might as well carry on how I'm going, But I'm just bringing that up because I think we need to look at those kinds of things because we know who we are. And just because somebody's prescribing to us, you know your own body. So I
Very true.
respect that.
I agree, May. That's a very good point. Doctors are healthcare advisors at best. And so point well taken for sure. Lynn, I believe you had a question.
Yes, can you hear me?
Mhm.
Well, the Montgomery County Director of the Department of Health and Human Services said that there is a shortage of behavioral health professionals and that community people, other people can be trained and provide behavioral health services. I'd like to have some people's comments on that. Thank you.
Delegate, if you want to take this, you're welcome to start and the others can chime in. But I know that access and cost related to mental health services is something that we'd all like to see from a health policy perspective be more accessible. So take it away.
You're absolutely correct. And it's an ongoing challenge. And in fact, some of the work that we did as a result of the pandemic actually was very it was actually very forward thinking in terms of the expansion of telehealth for behavioral health services. What we found was because we expanded telehealth and we were trying to be very strategic about it, telehealth has actually been utilized for behavioral health services for a number of years before the pandemic. But we really sort of expanded that. And what we found was that the utilization actually did not diminish at nearly the level as somatic care as we were returning to work, returning to buildings, because telehealth for behavioral health took away some of the challenges. It took away the need for childcare. It also allowed the providers to see their patients in their home environment and see if there were other environmental factors that were impacting. In terms of training for being a behavioral health provider, I suspect that that's along the lines of like mental health first aid, because we do have behavioral health services that people can train for. Like we passed a law a couple of years ago called Lorenz Law, which expanded behavioral health training to teachers so that there were, again, more eyes on those students. I think earlier you said that 1 in 5 adults has a mental health crisis. 1 in 5 children does as well. And in fact, in 2016, suicide was the #1 cause of death for children ages 10 to 14 in the state of Maryland. So we're always looking at ways that we can expand those resources, but also with ensuring that we maintain a certain standard of care, which is why there are certain services that can only be provided by a licensed health professional, because we often ask everyone to be a health professional except the health professional. And we really do want to make sure that we're making a robust workforce of health professionals to provide those services, because they have the training and the standard of care to provide those services. That said, we are also expanding behavioral health training to, like in Anne Arundel County, we have a first in the world crisis intervention team, and they are a branch of our law enforcement who have specialized behavioral health training. And so they work in tandem with health providers. So I'm not sure what Montgomery County is doing specifically, but I know we're always looking at creative ways of expanding that workforce because it is an ongoing challenge.
I can add to that. I think your point, Delegate Bagnall, is very well taken, that expanding access is important, but you want to maintain quality. It's definitely a challenge. Child and adolescent psychiatrists, I think, have the greatest shortage. There's the greatest shortage of child and adolescent psychiatrists of any medical field, or child and adolescent psychiatry has the greatest shortage of any medical field. But filling those ranks is complicated. On, of course, Medicaid, Medicare expansion, or one of those two anyway, and that is a hot button topic. So it is tough to get, to increase the workforce. Does seem necessary. What can be done in the interim? I think you've touched so beautifully on all these wonderful policies that you're trying to enact, the laws you're trying to enact, in terms of improving mobile crisis teams, improving inpatient services, outpatient services. There's a lot that needs to be done. Thank you for all you're doing.
If I may add something to that one, it's a question of market forces, supply and demand also. The psychiatrists are one of the lowest paid physicians among all the doctors. So from that perspective, everybody wants to go to highly paid cardiac surgeons like that one. So that from that perspective, you don't have a lot of psychiatrists. The same way, looking at the drugs in the pipeline also, there are a lot of cancer drugs in the pipeline. There are a lot of other drugs, but psychotropic drugs are least number of pipeline. The reason is return on that investment is minimal. So from that perspective, sometimes market forces play a big role in the demand and supply, and that's where we're missing.
Sure, thank you. Well, that was a great discussion, great questions. The Maryland OPPE, the seniors, African Americans, veterans, peoples with disabilities, LGBTQ plus, and DLCs, other DLCs spoke to raise awareness today for mental health challenges facing Maryland's diverse communities. In honor of Mental Health Awareness Month, we had this session. I hope you enjoyed it. We're going to conclude here. Thank you so much for joining today. If anyone has any other final thoughts, you're welcome to, but I really we all appreciate you joining today. Thank you.
This is great. Thank you.
Thank you. Great job.